With a focus on advancing emergency care, Zoll delivers innovative, user-friendly technology designed for where and how you work, and for the patients who rely on the care you provide. Zoll is committed to helping you save more lives.
Thank you, Ian, for the kind introduction, and welcome to everybody. It's a great pleasure to see quite so many people in the audience. This is not the first time. This is not my first time at SAMS. You might be surprised to know, but I do remember our maiden session where I was a bit worried at the time that the numbers of speakers would outnumber the numbers in the audience. Okay. But it falls to me to give a general introduction to the principles of palliative care, and then I will let my esteemed emergency medicine colleagues, continue with the specifics of what is it like working in the ED. Okay. The title might seem a little unusual to you, but I hope that by the end of about 17 minutes you will understand what I mean. Okay. So Joanne Cannon, who is an emergency medicine physician, oh dear, now why is it doing that? Okay, right. Has written in the Annals of Emergency Medicine this. And I think this illustrates very well what's happening to our young doctors particularly, perhaps I can't speak for the nurses, that when people elect to do emergency medicine, what they see themselves doing is lots of resuscitation and saving lives, and perhaps less about treating increasing numbers of chronically ill patients who are what we call the revolving door patients or the frequent flyer patients that come in and out of the ED, very, very sick, very, very symptomatic. And as you might have seen Prof. Manning mention in the video, it sounds like they or their families don't actually know how sick they are and the fact that they could die. So I'm going to start with a case that it's a fairly typical case, and you may have seen a patient like this in your very own ED. So these are actual ED notes. This is from a few years ago, as you can see, it's from 2013. And it's a 77-year-old Caucasian man with very advanced lung cancer, who is under HCA. HCA is HCA Hospice Care, which is Singapore's largest hospice home care service. Now, he fronts up at ED, having deteriorated very quickly over 2 days. The hospice home care nurses saw him and gave him morphine, which is the appropriate treatment. But because the treatment didn't work and he was really distressed, his family decided to call the ambulance and send him to hospital. And when seen, he was very breathless, he was very hypoxic, struggling to breathe, and totally exhausted. And in short, he really was dying from advanced cancer. So what would you do? Again, this is not unusual. And if you're seeing patients like this coming into your ED, I'm sure, right? Okay, so what do? I'll come back to this guy in a minute. And many times when I talk to my ED colleagues, the initial impression that I get from them is a great sense of frustration and helplessness about what they can do for this man who, at the back of their mind, is saying, well, you shouldn't have come back to us in the first place. That's not what he wanted. Okay. So what is palliative care? This is what the World Health Organization says palliative care is. It's just a preamble. There's about 1.5 pages of definition. But what I want to draw your attention to is what I have highlighted in red. Palliative care is really about improving quality of life. Well, at every stage of life, but most importantly at the final stages of life. And what we are trying to do is to both prevent and to relieve suffering. That comes through the experience of having life-threatening and terminal illness. And we are there for patients and their families. It isn't just for cancer. I know the example that I gave you was for a patient with cancer, but this is a position statement from America, from the American College of Cardiology and other, cardiac surgeons. And what it says here, and again, it's very similar terms I use, prevent and relieve suffering and to support the best quality of life. But what they have said is regardless of the stage of disease or for the need for concomitant therapy. So in many centers, in the United States, the moment a patient is put on a cardiac transplant list or acquires a left ventricular assist device, they get a palliative care consult because we know that these patients are at high risk of very poor outcomes. And in fact, in my hospital, we hope that sometime in the next couple of years, when NUH begins its LVAD program, that we will have palliative care running alongside. The truth is, there is a lot of death and dying in EMD. I'm using some figures from our hospital because I think numbers don't lie. And these are figures from my hospital in the last few years. about deaths that are occurring in ED, that's the top, and then at the bottom, in the general ward. And the reality is about a quarter of the deaths that occur in NUH actually occur in the emergency department. These patients don't even make it out of ED. Now, the majority of deaths in ED are, as you might expect, they're mainly cardiac in nature. But the people who go up to the ward are also really potentially dying. And many of them have medical problems. As you can see, the largest numbers of deaths are occurring in our general medicine and medical oncology, and hematology, for example, and cardiac. So actually the reality is these people are already potentially dying when they get to ED. It's just that they might not appear like they are actively dying at the time. And this is why most of us are not taught how to identify patients who might be at risk at death. Most of us know, in the last 8 years or so, a number of trajectories of dying have been started to be described. Now, these are the ones that ED is used to dealing with: the sudden collapse, the out-of-hospital collapse, the people who are walking around very well and then suddenly, boom, PA collapse, in they come. The other one that I think we are all very familiar with is actually the cancer trajectory. These are people who also remain relatively well, and then with advanced cancer, when they start to not walk so well, they start to use a wheelchair, they start to spend more time in bed, reasonably, you can be certain that we are looking at a prognosis of probably weeks to months. It's so reliable. But these two groups are the increasing numbers of patients in an aging society who are coming to ED. And these are people with chronic progressive illnesses and with frailty and dementia. So here is what we call the organ failure group, such as heart failure, COPD, liver disease. These are people whose trajectory or clinical course is punctuated by sudden severe exacerbations. And they come in very ill. But if you treat them, maybe you put them on NIV, you give them diuretics, 2 days later, 3 days later, they are reading newspaper. And they look quite okay. Sometimes they may return to their baseline, sometimes they may not. So over time, they gradually get sicker. The numbers of admissions get more frequent, and one day, during one of these exacerbations, they don't get better, they die. And the physicians often say, but it was expected. He was having so many exacerbations, and the family are shocked because they will say, well, last week he was just at Gardens by the Bay. The truth is, he was at risk of dying at any time. It's just that he did not look like it until the very few last hours or days of his life. And the final group, dementia and frailty, these are the people who are in our nursing homes. They are in the bed all the time, usually NG tube fed, on a catheter, and they cycle in and out of hospital with infections, etc. And their functional status never really improves, never really gets worse. And one of these days, big pneumonia, and then off they go. But nobody knows when that will be. But the effort that it takes to looking after them on a day-to-day basis is very heavy, and very often their caregivers are very burnt out. Okay. So I'd like you to keep these trajectories in mind because I'm going to actually take you through some of the numbers from our hospital. My colleague Raki, who will be speaking after me, was in 2001, she took the figures and looked at the patients over the age of 65 who died in EMD. And as you can see, about half were the sudden deaths, either in patients who had no past medical history or those who were just mildly ill, actually walking around, working. The other half were those with actually serious chronic illness. So we should have seen it coming. If not us, if not people in the ED, then at least their primary physicians. Then the other startling fact was 3 times that number made it to the wards but died the same admission. 12% of them died in 24 hours. So what these numbers are telling us is that really sick and dying people are coming through ED every single day in every single hospital in Singapore. So what do we do? So how can a palliative approach, I'm calling it a palliative approach, and I'm using my words very carefully because it is a little bit different from, say, the specialty that I do. The palliative approach can be done by anyone, anywhere, for any patient who has the need. And it's really about what you do if you can't rescue this patient anymore. What I do in my work is multidisciplinary team approach. I work with the teams who refer patients to me. I work with nurses, allied health, medical social workers, pharmacists. We do a lot of symptom management. That's a core part of what we do, but we also work very hard in supporting our patients and families psycho-emotionally and spiritually. We do a lot of communication. Never a week goes by if I'm not in a family conference. Sometimes it's 2 family conferences in a day. We also end up giving advice in ethically complex situations, and then we do a lot of liaising with community services for patients who want to be at home. They don't want to be in the hospital. So that's what I do. So how does that apply to the emergency medicine department situation? Well, I think the issues that are relevant to ED are these. Communication and decision making. That's really important. Without that, nothing else can proceed with the decision making. Symptom relief, I think, is a useful skill to have. And for those patients who are going to die in the ED, at least make sure that it's a dignified and comfortable experience. I'd like to stress that people come to the emergency department not because they want to and have nothing else to do. It's because they have nowhere else to turn. And at the end of the day, it's about making a difference to these people who are very distressed and to their families who are equally distressed. So let's go back to the patient. I'll tell you what happened to him. So there he is, if you remember, very breathless, speaking in single words, dying. So what do? Well, he was given morphine in order to relieve his symptoms, so he had aggressive symptom control. They actually spoke to the family to reiterate and to make sure that they understood what the goal of care was, and the family was saying, he wants to be comfortable and he wants to be at home. We only came because we couldn't get his breathlessness controlled where we were. Okay. They called the palliative care team and they called the HCA home hospice nurse to also get some advice and support. And to ask, is it possible for this man to die at home? And then started a care of the dying pathway, which I think Raki will tell you a little bit more about, or Sister Geraldine will. And I think some of the points to learn about this is that morphine is an excellent drug for dyspnea, but sometimes in severe cases, you might need midazolam. So that's where usually people, like the palliative care people, come in, because already everybody is scared to use morphine, and then you say, no, give midazolam. They, don't want. Okay. So people like me come down and say, relax. Okay? Relax. We also come with access to equipment like syringe drivers, battery-operated syringe drivers that allow patients to go home. So we actually prepared an infusion of morphine and midazolam and got the patient home. Hospice home care were there, ready to receive him, and he died a few hours later. Okay, so that's how this story ended. You know, sad, but also bittersweet ending for the patient and the family. Okay, I know what you're going to say. You cannot lah, so busy already. How? You cannot do that. Well, maybe you can't do all of it, but I think it's possible to do some of it, really. It is. You know, certainly what we've done in NUH shows that it's a little bit of a stretch, but it's not a huge stretch. I think many a time the barrier is here. It's not anywhere else, it's just there. So the hallmarks, these I think are the hallmarks of EM practice, aren't they? Teamwork. You are very protocol driven, you work in teams. When you have a trauma case or a crash case, the entire team is mobilized and you all know what to do, and you all cooperate and you do what's best for the patient. You're really good at problem solving. That's what you need to. That's your bread and butter. Get to the heart of the problem, get the decision made. And you act swiftly and decisively. There's none of this, I'll just run some more tests, maybe I call my friend, I'll come back in half an hour time. No such thing. Now means now. You know, that's kind of what I do too. The thing is, when a patient is actively dying, you don't have the luxury of a second chance. So you've got to get it right the first time, and you've just got to bite the bullet and do it. And that's what I mean. You know, I think we have a lot in common. And therefore, that's why I chose the title. Same, but different. So in conclusion, very ill patients are going to continue to come to ED. Our population is getting older. Our community service supports are very inadequate to serve their needs. So they're going to come. Accept that. You will still need to respond in an emergent manner. Because, as I said, there is only one chance to get it right. And what you do for the patient, their families will remember forever. And it's not about doing everything or doing nothing, but doing the right thing. And it's not easy. I'll be the first one to tell you that it isn't, but my belief is things that are worth doing are often not easy, but it doesn't mean that we don't do them. Because I've always believed we can make a difference. Even at the end of life, where other people have said there is nothing more that I can do for you, I don't believe that. We can always make a difference. And with that, I thank you very much.